So Ramesh, I'll let you know once we are live on YouTube. Just take a minute.
Hello, everyone. Hello, everyone. This is Ramesh Raskar, and welcome to our session on efforts for PathCheck to deal with India's spike. We welcome you to join our website at pathcheck.org/India, and also our Slack channel, tiny.cc/pathcheck/Slack. I'm joined by our research manager, Rohan Sukumaran, and our Karuna project manager, Iman Shafi. Today, we have an exciting lineup on how we can use digital tools to deal with the pandemic, and especially when it comes to India, how do we use these digital tools to deal with the future waves? Next slide. The role of PathCheck Foundation is to figure out how we can fill the gap in the public health knowledge that leads to uncoordinated response, that leads to inefficiency, that leads to confusion, and even lost lives. So on one hand, while public health does as good a job as they can in test, trace, vaccinate, and treat, create some prediction models and even alert, as you can see from these dotted lines, there are significant gaps. And our role at PathCheck is to use crowdsourced citizen data that could be actively contributed by the users, but also could come passively through other secondary sources, these indirect signals, to fill the gaps while maintaining privacy and personal liberty. So, and for that, we have to capture the data in unique ways, not just depend on governments to provide it. We have to analyze the data using new technologies, not just traditional prediction models. And most importantly, we have to engage individuals, not using a one-size-fits-all type solutions or some kind of a broadcast messaging, but engaging with the citizens where they are, and when the appropriate time, through apps, through personalized messages, and making it, a behavioral change. So next slide. As you can imagine, this requires, a very serious data and software-centric approach. So we're delighted with hundreds of professional volunteers who work on the PathCheck platform from many parts of the world, who are right now focusing on the efforts about India. Today, we're going to talk about 4 different things. Initially, we'll hear about some crowdsourced methods using surveys. Then very briefly hear about the telehealth, which is a teleconsult platform, which is not just for teleconsulting, which is important, but again, the data that comes through this teleconsulting platform and how that allows us to create a bird's eye view by sampling it. Then we'll hear from Dr. Christine Glorioso on predictive modeling, and then Professor Pritesh Sethi on language models. And in all of this, when it comes to crowdsourcing, our goal is not to be comprehensive or coercive. The idea is very much like Waze for health or Google Maps for health, where you might have only 1% of the population using Google Maps, but as they start sharing their GPS location, it's enough for us to understand if there's traffic ahead or not, and or any problems in navigation. And so in this pandemic traffic, all we're looking for about 1% of the population to contribute the data to this crowdsourcing platform, which could come again from their apps directly or could come from secondary data that's already available. So we want to use this 1% of data that's coming through to have a very good insight on what's going on, also have a very good foresight of where we could go, but also look at the hindsight of the epidemiology of this disease. With that, let me hand it over to Rohan Sukumaran for the next part of the program.
Thanks, Ramesh. Thanks a lot for setting the pace. So as we discussed, we'll be discussing about 4 important things today. So I'd like to welcome Imane to talk about crowdsourced surveys and how we're using it in our app, the Karuna app.
Awesome. Thank you so much. Yeah. So I'm also joined today by Anirban Akandu, who will be able to explain a bit more about the surveys. But just to start off, this is currently our workflow for both the crowdsourcing and then what we'll be doing with it. So at first we started planning, identifying where is the problem, how we could get answers from individuals in India, and then afterwards brainstorming. So the survey preparations, what kind of questions, how many translations we can get, but also where we can put that. And that's where step 3 comes in, the application. So the app integration with the Karuna app. So currently we have the first version of the Karuna app, which is integrated, such as the COVID relief app created by the 3 founders, so Milan, Swapnil, and Praneet. And we are currently working on also adding for the Karuna version 2, the vaccination. So people will be able to have notifications on vaccination slots being open and also be able to auto add for a slot for vaccination, such that they'll be automatically added to a slot whenever one is open without having to always reload the page for vaccination. So those are very, very key aspects of the applications we're looking forward. And then once we get all of that data from the application, from people using the application and filling up the survey, we can also do a lot of outreach. So this is the volunteer-based workforce working on the ground with the Indian cities, but also it has to do with the telecommunication, with helplines, etc., getting data through people interactions. And then finally, with all of that data, we can do analysis. And so this is what will be presented afterwards in terms of predictive analysis. So if you go to the next slide, please. In terms of our crowdsourcing survey, we currently have our first patient survey out on the Karuna version 1 app, so previously known as COVID relief. And this is really just an anonymous survey used to capture the COVID-19 symptoms, the diagnosis, medication, etc. prescribed, and also the types of tests. So we know in which state vaccinations are being prohibited, but also in which places there are outbreaks of COVID-19. And this is very important to know where we can actually put out resources. So this is our first survey we've brought up. And then additional surveys we're working on is the hospital survey. So this is a survey to capture hospital requirements, any deficits, and those will be used by doctors, hospitals, etc., to tell us where are the places we need to send resources to, what do hospitals need the most. And our current hospital surveys is being developed in collaboration with doctors, medical students. Here, Dr. Yerit joined us as well, who has been very collaborative in this effort. And then finally, we're working on mental health survey. And this is really just to understand the mental health status of healthcare professionals, because right now the COVID-19 pandemic is a heavy burden on hospital staff, doctors, nurses, etc. And we don't just want to provide this survey to help us understand what's happening, but we also want to give a possibility after filling the survey in the app to give resources such as meditation videos, helplines, but also the possibility to talk with professionals with helplines, and that will be in collaboration with the telehealth communications. And so these are very important projects that we're working on, and we're always looking for volunteers. To continue on and discuss a bit more about the distribution we're currently looking at for our patient survey, I'll leave it to Anirban to explain a bit more for the next slide as well.
Thanks, Iman. Am I audible? That's good. Okay. So Iman very nicely said that we were working on these 3 surveys, and the purpose of this survey was to gather the crowdsourced data and then resolve it at various levels to see how the pandemic was changing form in India right now. So Rohan, can you please go to the next slide? Yeah. So we first decided to kind of see how many responses we got, because if there were not many responses, the trends would not be very statistically accurate. So Milan and his team, Swapnil, they were they shared the data with us in an Excel spreadsheet format. And we found out, like, we first resolved the data on the basis of age and on the basis of responses by various states in India. And we find that the adult population has been filling up the form, like most of the numbers are from the adult population, followed by young adults, that is 18 to 24 years of age. That's in the left side of the graph. When we resolved the data on the basis of state to this question, were you ever diagnosed with COVID-19, we saw that only certain states had higher number of responses, like Delhi, Maharashtra, Karnataka, Rajasthan, than the others. So we basically need to share this survey as widely as possible to obtain a better overview of what's going on. So we also decided to resolve the data on a temporal basis for the various states to see how the survey had reached the population. So Rohan, can you please go to the next slide? Yeah. So you see in certain states like Chandigarh and Jammu and Kashmir, for example, Odisha, you only have like one response, and that's on a particular day. So the reach is very poor. Most of the states have good responses, but if you look at the y-axis, it's like the number is pretty low. It's 3, 4, maybe like 10 maximum. That's all. So this data, we basically want to ask. We basically want your help to get this survey to as many people as possible. Share in the relevant platforms, LinkedIn, Facebook, Twitter, because this data is very important. This gives us like a real-time present scenario, an immediately past scenario of how the pandemic has affected the people. And there are a number of key questions in the survey, like vaccinations, hospital beds, like which type of hospital were you admitted to? Did you get oxygen, for example? So these data points are very important. So this is our humble request. If everyone can please share this survey with their contacts, that would be very helpful. Thank you.
Awesome. Thanks, Anirban and Imani, for that overview. And definitely one thing to highlight over here is all these surveys are completely anonymous. We're not collecting any personal information, and it's completely privacy preserving. So yes, any help which we could get for getting this crowdsourced information is highly appreciated. With that, I'd like to welcome Dr. Swami Iyer to talk a bit about Televate, the tele-education platform which we're running with the help of 100 plus clinical and doctors behind it. Dr. Swami, over to you. Dr. Swami, in case you're speaking, you're on mute.
Oh, I'm here. Apologies. I was muted.
Okay, cool.
Can you all hear me?
Yeah. Yes, we can.
Okay. So good morning or good evening to you all in India, and good morning in the US. I'm Dr. Swami Iyer. I'm a professor of medicine at MD Anderson. I think Dr. Rajiv Gupta, I saw he is also on the call, and worked very hard to develop this teleconsultation or teleeducation platform that allows doctors to talk to each other, any healthcare worker for that matter, not necessarily a doctor, including a nurse, including anyone that has a direct responsibility to patient care and wants to ask a question. And perhaps they know the answer, but sometimes there's so many things going on, they want to have some kind of a sounding board. So with that idea came this tele-vidya or tele-education, which makes this happen. And next slide, please. And currently, there are at least 8 hospital systems that have signed up. The way this televidya system has been set up is through a company called Teledoc, which works in the UK and provides service for direct patient care through teleportals through the National Health Services, the NHS. They also provide service for the insurance companies in the US, such as Aetna and Cigna. And so it's a very well-known company, and they have the networks and everything set up. And the doctors on one end make a call through the system, and the doctors outside of India who are all signed up, there are 130 doctors or so who have signed up, are in a position to able to talk to them, answer questions, and much more. It's a relationship that builds, and the whole idea is to trying to act as a non-playing captain in an objective manner to help with patient care. Also, there are other possibilities, but the main goal here is to take care of some of the acute concerns that the doctors might have with the patients. And the expertise spans across pulmonary and critical care, ENT, ophthalmology, particularly with the rise of mucormycosis and non-availability of medications and how to manage those. Infectious disease doctors, and there's several others who might come in some kind of help to make this happen. Of course, it also opens up possibilities that materials can be sent and other discussions can happen through a lot of humanitarian organizations that are going on. So it's a very nice platform. As you can see, there are 8 systems, mostly in Maharashtra and Karnataka. Rural India is probably hit the most at this point. And the cities are reeling from the COVID and the long COVID at this point. So a lot of these are questions that come up that might need help. Next slide, please. And so this is the sort of the ad that has gone out in terms of televidya or teleeducation. And this is the contact number to email, televidya@careinc.info. Ms. Medha Naik has been very helpful in putting all these things together. I should say the kudos goes to Dr. Raj Gupta from MGH Harvard and Rajesh Makija to have come together with all the negotiations and a lot of the pieces together and trying to get the legal consultations and legal concerns alleviated. And Dr. Subhash, Meera Subhash, and Dr. Priya Ramaswamy from UCSF. Thanks to the help, I think this platform is ready to go. So if you know anybody who needs help, please have them fill the Google form or email televaidyya@careinc.info, and we'll get in touch with you and we'll get this going. It's ready to go. Thank you. I'll stop here.
Awesome. That was great, Dr. Swami. And thanks, Dr. Swami and Dr. Rajiv, Dr. Priya, Dr. Meera, and Ramesh, Rajesh, and Medha for putting this platform together. This is really an amazing platform for helping the healthcare workers. So this, I'd like to call Dr. Kristen Glorioso to speak a bit about the predictive modeling work that's been happening. So over to you, Kristen.
Thank you so much. So yes, as Rohan mentioned, I am leading the predictive analytics channel in the Slack for PathCheck, and we have about 75 people in the channel. I think about 30 people are actively working on a bunch of different projects. So we are kind of moving at warp speed here, working on stuff, especially since it's a crisis situation. This makes a lot of sense. And I'm also a member of the team that's looking at COVID variants, and that's led by Professor Iyer, who we just heard from. So I'm going to speak a little bit about his other hat, with his permission here. But I'm going to start here with just kind of an overview of the projects we're working on in predictive analytics. So we're working on 2 different levels of predictions. The first one is at a population level, and this is for informing policymakers and hospitals about what might be happening with COVID in the future. And the second is on a personal level, informing individuals, which is something that is desperately needed during this pandemic. So on a population level, we're really looking at 3 different timeframes for predictions. The first is current, and you might ask, why do we need predictions for current situation? And the answer is, as many speakers before me have alluded to, that we really don't have good data right now. So, being able to use surveys and Twitter and other indirect means of data collection in order to understand what's currently happening is actually pretty valuable. And then the next time frame is 7 to 14 days from now. And this is really our early warning for emerging hotspots. So this is what is going to happen in 14 days. And this time period is very important because this is the amount of time that will allow oxygen to get to places in time, that will allow hospitals to prepare, that should governments decide to take action in terms of non-pharmaceutical interventions, this gives them enough time to implement that. And then the last time frame is really 6 weeks from now, which is long-term predictions that include variants that allow for long-term policy planning. And the output of this is really maps. So maps and visualizations that can go in apps and dashboards, can be shot out over social media. We're also working on a number of publications, preprints currently. So that's really at the population level. And then on the personal level, which can also have the same output for apps, dashboards, social media, we're working on a number of projects, one of which is a risk calculator. So a question I get all the time online, because in talking with the public, is, how risky would it be for me to do X activity? For example, go to an indoor restaurant in my area today, and how can I lower that risk? So masks, vaccination, how do the variants impact it? How do the type of vaccine impact it? Is it different for kids? What if I'm vaccinated, my kids are not? So this kind of risk calculator can be very useful for this and would be a nice addition to apps and dashboards as well. So I'm going to focus more in depth on the two projects right now that are furthest along. One is the early warning for emerging hotspots, and the second one is really a project with the variants team that we're writing up this week. Next slide, please. Okay, so emerging hotspots. So here's the big question, and this is also for current levels of COVID risk. How do we obtain accurate case number data when there's insufficient testing, reporting delays? People have to take a COVID test, it then has to come back from the lab, it then has to be reported and then uploaded to databases, and also data fraud. So we know that there is a number of different, accidental and purposeful suppression of numbers in COVID around the world with various governments. So the answer, crowdsourced surveys, which you've been hearing a lot about. So you can simply ask people about their symptoms and about people they know that have symptoms, and get an idea in real time earlier than you would and more accurately than you would just from reported numbers. So this graph I'm showing you here is active cases in Delhi over the last 4 months. And you can see this huge spike, of course, is what happened when the hospitals got overwhelmed. And this is two different measures. So in blue are symptoms, active cases as measured by symptom surveys. And these surveys are University of Maryland Facebook surveys that we get about 3,000 responses a day in India. This red line is what the government was reporting for cases in Delhi, but times 10. So just to show you on the same axis, we had to multiply by 10. So it's really down here. And you can see two things in this graph. The first is that there are more than 10 times as many cases that we predict to be happening than as reported by the government in Delhi. And the second thing is this lead time. So we're seeing approximately 10 days early warning. And I should say all of this is a collaboration between myself and the team at Karuna Surveys, David, Antonio, and Carlos, and Govind, who is a software engineer. And this is where you can find this survey data. Next slide, please. And this is just our first attempt. So this has not gone out over social media, but this is just our first attempt at showing you what this could look like in an app or on a dashboard. So on the left are the current, what was happening currently on May 13th, so 12 days ago in India. The darker red areas have more COVID cases. And then on the right are areas that are gonna have increasing risk or decreasing risk. So you can see this area in the Northeast was predicted to be going up in India, whereas the middle areas were predicted to be dropping in cases. And just today, we saw some newspaper reports confirming that the Northeast is likely the next big hotspot area in India. So this appears to be a method that's working, although we're still ironing out all the details. Next slide, please. So I'm going to move on and tell you about some work with the variance team. So this is a collaboration between myself, Pawan, Mang, Rishabh, and Professor Iyer, and with help from Rohan and Shailesh and Chitra, who's a virologist in India. And our working title, so we're writing this up this week. This is a project on COVID variants of concern. It's primarily taking place in the US, but there are some interesting overlaps with India that I'm going to get to. So on the left, this is my US COVID cases model in blue, and this is reported cases. And you can see that it was extremely accurate for about 9 weeks from December through mid to end of February, where it then took this left-hand turn. And when I looked further at why there was this sharp deviation from the predicted decline in cases, we found all the cases to be clustered in sort of the Northeast US, surrounding New York. Next slide, please. And when I broke this down further, the reported cases by state, you can see that there were states that deviated and looked like this deviation in the overall model. And then most of the states were going down as predicted by the model. And these states were all these Northeastern states: New York, New Jersey, Connecticut, Rhode Island, Pennsylvania. Next slide, please. And when we looked at New York at almost exactly the same time, you see the original variant. So this is variant percentage, and these are the various COVID variants, and this is over time. You can see this mid to end of February, we see a switch from B1.2, which was the predominant variant at the time, to these two variants of concern, B117, which is the UK variant, and B1526, which is the New York variant, as well as lineages of 526, 5262 with 5261 also popping up. Next slide, please. So we investigated further. This is work by Pawan. He looked at just simple linear regression of the various lineages in terms of, so each of these points is a different state in the US, and this was in January, February, and March. And on the top, you can see these three variants I'm showing you are just the most significant ones. These are all the New York variants, so B1526, B15261, and 5262. You can see in January, none of them were very significant, but as you move through February, that same cutoff where we started to deviate into March, you can see that these the amount or prevalence of each of these variants in the states was correlating highly with number of cases per population. In fact, 5262 was the most significant and had a p-value of 10 to the minus 9th in March versus cases. Next slide, please. So why would this variant, possibly be resulting in these cases to pop up? And this is this middle panel is a beautiful slide that Professor Iyer made, and I kind of borrowed here this morning. And what was going on with these variants is that they have, so this is a picture of the coronavirus itself, and these little tufts on it are spike protein. And these mutations are actually changes in, result in amino acid changes that change the shape of spike protein. So this is a top view and the side view. And so what happens is that they change shape and then can no longer be recognized, for instance, by antibodies that are produced either by vaccination or previous infection. So these conformational changes actually result in the virus being able to escape immunity. And when we looked by mutation instead of by lineage over on the left, we found something very interesting. So this is also analysis by Pawan. You can see that, so these are the Indian variants, the US variants is in the UK, and this is the Indian variant in the US in New York. We now have the Indian variant in the US, And when you look by the most significant mutations, you find that there is this mutation, T95I, which is in common between the Indian variant and the US New York variants, suggesting that there is some sort of convergent evolution where they both ended up with this same spike protein mutation independently. And when you look at India, these variants now are 617 and 6172 are now the predominant variants in India, and have basically taken over all of the cases are now these variants. Next slide, please. And this is work by, this beautiful diagram was made by Rishabh. And when you look at these various mutations, so convergent evolution means arising in different countries and different places, but coming to the same mutations. And obviously they're offering a selective advantage. So this T95I is this orange triangle here. You can see that it pops up in the New York variant and the Indian variants and this variant over here in the United Kingdom. And you can see many of these mutations that are associated with immune escape or increased transmissibility are arising independently in different countries. And that is one way to sort of get a grip on which of these mutations is most important for escaping immunity, for traveling faster, causing the spikes that we saw in India and the lack of cases going down that we saw in New York. Next slide, please. So this is my last slide, and I'm just going to leave you with this open question. So have we had not just one, but several pandemics? So these are variants over time since the beginning of the pandemic in the US. And, you know, we kept expecting cases to go down, but you can see each of these spikes is actually associated with a different variant. So in the beginning, you know, we had just normal B1 and B2. This is the B1 variant, but then the big spikes in the fall in the US were associated with B1.2, right? And then here in the spring, we start to see the rise of these variants of concern, 117 and 526 and 5262. So in a sense, if there is some, you know, way that these are escaping immunity, we have had part of the reason why we may be so frustrated and what was happening in India, we expected things to be over, is that in a sense, they were over for those original variants, but it's these extra special properties that are allowing a second wave or third wave of the pandemic to progress. So with that, I'm going to stop here. Thank you very much. And thanks to everybody that's been working on this stuff with me and all the wonderful, talented people in predictive analytics. And please do join in on the projects. We can always use more help. Thanks.
Awesome. This is indeed great, Kristen. And thanks a lot to all the collaborators who's been working tirelessly on this. These are amazing solutions. And we look forward to getting more of these relevant works outside as soon as possible as well. So with that, I'd like to call Professor Pritesh Sethi from IIIT Delhi to talk about how he's using language models for genomic sequencing and a few of the other works where he's working on regarding this information. Over to you, Dr. Pritesh.
Thanks, Rohan. Pleasure to be here. Next slide, please. So I'm going to talk about language models from emotions to genomes, as we have actually encountered these during the pandemic over the last 1 year. So as we were discussing before, data are hard to get in India. So one decision that we made in the lab was to get the information that we can actually mine from available data sets as signals using indirect data sets. So most of the work that I'll be talking about today is going to be about mining information from indirect data sources, for example, Twitter, social media, or even genomes, right? So, and here, I mean, so one of the key directions that we have been working in is how to deal with the infodemic, because alongside the epidemic, the infodemic has created equal problems. So Delhi or Indian districts, states, now villages are an example where misinformation has been an equal challenge as the spread of the disease itself. So I'm going to speak about how language models that we have been working on in our lab over the last 1 year have helped us gain a little bit more insight on the pandemic. So going to start with this work, which is recent, which is on mining trends of COVID-19 vaccine beliefs on Twitter. I understand Twitter is a very urban phenomenon. It may not be applicable to the rural areas of India, but at least it helps us get insights on uh, how the beliefs kickstart in urban locations. And most of the times, the pandemic then, or the epidemic then, spreads from urban to rural areas. So what we did in this work was to use language models to understand what is a lexical space of vaccine hesitancy, which essentially is mining emotions that are associated with vaccine hesitancy. We have had a previous work on it, which correlated the emotions that are put out on the public domain by emotions reflected in the public domain documents put out by the government, and comparison with what public actually puts out on Twitter, and how are these related. So that was a paper on the relationship between these, but this actually is an extension of that kind of work, where we defined about 20 lexical categories, including emotions such as hesitation, sorrow, faith, contentment, and also their influencing factors. We use machine learning to expand the scope of lexical scope of these words, because we want to cast the net out wide and essentially capture some of these key relationships using word embedding models. These are the same kind of models that that are used in, for example, Google uses to predict the next word when you are typing your email. And we find that these lexical spaces are very different for different geographies. For example, India versus the US, their trends change as the pandemic evolved. For example, after the announcement of the vaccine rollout, or after the announcement of the approval of the trials. So for example, here you see what the comparison between India and the US in terms of how misinformation changed, or faith upon vaccines changed in India and the US. And these were different after the announcement of the vaccine trials, which means that we have to segment out our messages carefully and tailor them to tailor these to certain geographies. Next slide, please. We also understood, from this analysis, we also try to understand how do these relationships between emotions evolved in time, and how did these come together. So one of the figures in our paper talks about the correlation of misinformation and hesitancy in India, whereas it is a very different state in the US, where contentment, faith, anticipation, and vaccine rollout came together. Again, pointing out that now if you start looking at more granular data, you go down to states in India or districts in India, and looking at the kind of surveys data that PathCheck is collecting, we may be able to understand, and we may be able to segment and design tailored sort of interventions for these geographies using similar approaches. Next slide, please. So in the infodemic scenario, one thing that I did not talk about Twitter was we also recently constructed models that actually predicted whether a given piece of information is true or false on Twitter, using machine learning models, using very simple indices, for example, readability of tweets, and so on, and also combining these with word embedding models. And surprisingly, what we found was some features which are, for example, number of exclamation marks in the tweet, or what's the readability of the tweet. These actually predict the misinformation score, and more the exclamation, more the use of capital letters in a given tweet, shorter the caption, more likely it is to be a misinformation content. So very early on in March of 2020, we had started out this Wash Karo initiative, where we wanted to address this misinformation by building out language models for reaching out to public in their own language, Hindi, and creating bite-sized audios for the content that was matched with WHO documents. So the idea was to provide the right information to the right people in the right format at the right time, essentially meaning that all the guidelines that are put out never reach the rural parts or even the urban parts of India where native language is not English. How do we mitigate that scenario was the challenge that we were addressing in the Washkaro project. Next slide, please. And the way that we did it was by, this is the Washkaro engine. We matched the WHO and CDC and Ministry of Health and Family Welfare guidelines with documents with what's put out in the news. We summarize these using text embedding models, using word summarization models, and essentially generated similarity scores. And these were vetted by humans. So it's a human in the loop AI. Clinicians actually were on the panel to vet some of these pieces of information. And these were then translated in Hindi using text to speech and translate APIs. And then we allowed users to give feedback on the content. Next slide, please. So in the brief 3 months that we had online with the Washkaro COVID app, we were able to demonstrate that segmentation is possible using machine learning and AI for mitigating the infodemic. This was majorly targeted to the Indian population. And the figure on the left shows how the relevant information as voted by the users increased over the duration during which this app was online. Unfortunately, the app was taken off because of the COVID-19 policies, which disallowed any non-government apps to be on Google Play Store. But then we actually raised a request, and now we are back on for the last 1 year. We have been working on TB information in the Washkaro app. But we were able to also then show that more females were engaging with the app in Hindi than males. So essentially, again, pointing out that how do we segment out messages relative to given locations, and these are all pointers that we can build into, for example, the Karuna app engine. Next slide, please. Finally, I'll talk about how language models can also be used for understanding the spread of the strains and the virus by applying these to the genome sequences. Now, this was a project that we started early in January, essentially with the idea that there was a paper out in Science, and it was almost at the same time when we were thinking about this idea, but a paper in Science by he et al. Pointed out that genome, amino acid sequences can be read as a book by language model. So this paper in Science talked about how the coronavirus sequences can be understood with these language models for viral escape. We were taking a different approach. And we were happy that it was not exactly overlapping. What we were doing was we were looking at the DNA sequences themselves and essentially breaking these down into 3 mers and using language models to understand how these sequences changed in time and across geographies. The underlying thought is that most of these word embedding models look at the context. And none of the mutations, it's known that long-range correlations exist in the viral genome, which means that if we look at the k-mers in isolation or even correlations, we may not be able to capture the long-range relationships. Whereas language models are known to capture some of this. So we posted this preprint on bioRxiv. It should be online in a couple of days. So there's a lot of information on how we actually have done this, but the basic idea was that we had some initial sanity checks. For example, word embedding models were constructed, and we optimized for the number of dimensions, because a viral genome, we don't know how many latent dimensions may exist in the word embedding models. So think about it as a vocabulary, and now we are trying to map that vocabulary of 3 mers onto a smaller dimensional space in which each dimension has a lot of nonlinear dependencies. So how many dimensions do we keep? That was our first question. So in the paper, we talk about some cool techniques to optimize the number of dimensions, essentially using a special loss function called the pip loss. And then we showed that similar geographies, for example, England and Scotland on the left, whereas England and Brazil on the right, were showing very different patterns of blips. Now, blip is a change in this dimension, in these latent space dimensions, right? So these blip patterns in these dimensions were different across geographies. On the right-hand side, you can see that these geographies were actually captured on a phylogenetic analysis also, not only on just on the basis of geographies, but also on a temporal basis. I'm sorry for the small font, but if you zoom in, you will actually see that if you go around the circle, it actually captures the temporal date structure as well, although our word embedding models did not have any information on time in our models. So we showed that our t-SNE plots actually captured these geographical and temporal differences that were coming up in the latent space. So we are not looking at the 3 MERS, but we are looking at a latent space and then essentially creating word vectors to start using these for predictions of what may happen next. So these radar plots actually show how the bottom left radar plots show how latent dimensions changed from November to December to January across 3 countries, Brazil, England, and India. And we see that very similar changes, again, a very similar thought on convergent evolution that we were talking about, happen in the latent dimensions also. Next slide, please. So we essentially then mined for what is the biological significance of these dimensions, because these dimensions by themselves are non-interpretable. These are black box dimensions. And we found what are the most heavily weighing 3 MERS on each of these dimensions. And I'm showing here dimensions 3, 12, 13, 15, 30, and 33, because these are the dimensions which could actually predict the new case load 1 month ahead of time. And how am I saying this? We constructed a lead lag kind of time series analysis where we, on the top right plot, you are seeing the cross correlation between dimensions and new cases. And essentially, some of these dimensions, not all, were in a leading relationship. And you can see that the red curve is the blip counts in a given dimension, and the blue curve is the new cases in the following month. And you can see clearly that that the number of blips in these underlying dimensions follow a very clear pattern that we can start using to predict what may come up next. Again, this is a indirect information that may help us gather insights into what can be expected numbers in given geographies. So we built machine learning models. Bottom left figure is a variable selection analysis which shows which of the dimensions were significant. The box plots in green are the dimensions that are significant, and you can see that the dimension 3 is actually significant. And we also show that dimension 3, the k-MERS that are weighing heavily on the dimension 3 are actually important when we map these back in our discussion section in the paper to the variance of concerns. So we call these dimensions of concern. The dimensions that lead the new case count, we propose that these are the dimensions which we need to track across different countries, because these may be reflecting convergent evolution. And the bottom right plot exactly shows that there's a leading relationship between Brazil and England. Paper talks about more also in India. So these dimensions of concern can be used to forecast cases ahead of time. There are also dimensions which show changes after the case load has increased, which means that mutations and new case load is a chicken and egg problem, because if you have more cases, the virus also multiplies more and there's more mutations. So we are only interested in mutations which actually lead and do not lag the new case load. Next slide, please. So that was our, so I think this slide is missing a lot of pictures. This may be a previous one, but I wanted to put all the team out here. The slide was full with my team members and who have been working as interns, volunteers, and really grateful for all this support. Thank you so much. Happy to take questions.
Thank you, Dr. Pritesh, for this exciting presentation. And definitely, I'm sure there are like a lot of questions that folks are having on this. And with this, I'd like to quickly allude to the few other initiatives that's happening on works with PathCheck. So one is the pulse oximeter by making use of Samsung phones in rural India, or the S6, S7 old version Samsung phones, which has an inbuilt sensor onto them. We're working on creating that as an adaptable pulse oximeter sensors. And anyone who's interested to work on that, please do join our channels and we can interact on this. Further, we are also collaborating with the largest online pharmacy company, 1mg, where they're looking at medication trends and what people are searching to understand epicenters of case evolution and how the spreads are happening, and mapping the mobility directions of what spread is going on. And on top of this, we have the Karuna crowdsourcing app, which is to be the one-stop solution for getting all needs regarding medical information, surveys, touch points, reaching out to doctors, etc. So thank you everyone for joining us today, especially thanks to Iman Shafe, Anirban Kundu, Dr. Christian Glorioso, Dr. Pritesh Sethi, Dr. Swami Iyer for giving these wonderful presentations and working tirelessly with the team. And this has been an amazing initiative with the help of lots and lots of team members whom I couldn't name right at the moment, but this is efforts from 50 and hundreds of people together. So thanks everyone for that. With that, I'd like to just bring us back to the discussion. Please do join our Slack channel at tiny.cc/PathCheck Slack, and join the #April Spike channel and reach out to us if you're interested to work on any of these projects, and we're very open to collaborations. So with this, I think we can open to Q&A. I've been seeing a lot of chats and questions coming up, so I think we can start with the Q&A. So if anyone has any questions, kindly do post it on the chats or the Q&A section, and we can discuss it. So otherwise, the panelists, please feel free to unmute yourself and ask any questions.
I think there's been a lot of questions concerning prediction. I'd like to discuss also with Kristen, Tav, and the other panelists here. I see that you have one for prediction for COVID, and then the other one is really more, it's a lot of language analysis. In terms of, merging the two, would it be possible to look at, Twitter, the social media, the language, and see if based on the emotions, as you listed, Tav, we could have some sort of prediction for COVID to use as well with our current predictions of hotspots in India. So would that be a possible collaboration with the two?
Yeah, I can. So definitely. So actually, we are having a meeting about that in half an hour on that collaboration. So yeah, definitely the Twitter data can be added in with the Facebook data, and we have that in the works for sure. And other signals, including last week we heard from 1mg, and it's also possible to include them in this collaborative effort.
Right, that's interesting, definitely. And based on a discussion that I had with Professor Srinivasa from IIT Bangalore yesterday, his question was more along, are we looking at the monsoon model for prediction? Because in India, monsoons become quite intense, and at places it leads to floods, or even if there are not floods, there are the entire climatic conditions is pretty rough. So the patterns of generic diseases itself rises, so like common cold or the flu equivalents of the US, they are on the rise in India when generally during the rainy season. So his question was more along, are we trying to incorporate these elements into our models, and what sort of benefits / issues do you see with adding such weather related information, any sort of confounding effects, etc.?
Yeah, I can. So one thing that I showed my model that I had in the X Prize Challenge, the original model, and I did have super spreader events as part of that model, and I haven't really had a chance to talk much about that, but there is a way to add in these events, because that is the biggest way that actually COVID is spread, is through these super spreader events. So you can imagine something like a monsoon could lead to super spreader events if people are gathered in crowded spaces. Other things are holidays, parties, weddings, these kind of things. For weather in particular, so there are a couple of things with weather. One is that temperature has some effect, but it's not a huge effect that we see on cases. And it's a little bit of a problem to disentangle temperature and weather from other seasonal issues. So, for example, Nina showed a while back, who was also in the X Prize, whose team actually was one of the winners of the X Prize, showed that schools and workplaces, but schools in particular, are associated highly with COVID case numbers. And we also know schools have a seasonal pattern, right? They're closed in the summer, they're open in the fall and winter. So it's hard mathematically to disentangle what is a weather pattern and what is a. So we have to be very careful about that.
Dr. Prasanna, I'm muting you because there's a lot of noise coming in. Sorry for that. Yeah, but please continue, Christian.
Yeah, so that was basically it. We just so we're working on some like techniques, and we could try to do there can be some things we could probably do to try to disentangle that with causal inference and other things, but we haven't quite gotten to disentangling weather from schools and other seasonal things. If that's basically the short answer. I don't know if other people have thoughts on that in this panel.
Interesting. So yeah, I think what you're saying definitely makes sense, and probably we can look into it deeper with other sources of information as well. So there's another question. There's another question from Palika Kanani. So she's asking if there are response from social media companies in contributing data to this effort. So does anyone in the panel want to take up that answer?
So the data we're using right now is Facebook data, because actually that's the Facebook survey data, because that has the most responses so far. We hope to ramp up the PathCheck data. I have it on my short to-do list to try to get in touch with Facebook. I'm not sure that they know how valuable their data sets are at this point. So we would like them to be aware of it, and maybe they would be interested in because it would be kind of low-hanging fruit for them to advertise their own survey for free. But we still need to do that. I don't know. I think Todd maybe has some other comments on this, perhaps.
No, I agree with you, Christine. Been a part of Facebook conversations. So mostly it's surveys data that are currently open to researchers. But I think, yeah, so there's also Twitter COVID data set, but I think it needs to be a lot more openly available to the public in general to push the research. It's not that these are difficult to obtain. But yes, I think there's a lot of scope for more focused collection as well as availability, making these data available to researchers as I believe. I mean, so there's various efforts, and also in tandem with what is happening in ground rather than retrospective. So one thing I believe very strongly is that even our models, unless we actually become prospective and proactive in our models, we can demonstrate tools and approaches, but really organizations, institutions, governments have to be much more proactive in putting these data out so that lead time can be gained. So that's where I think indirect signal mining from crowdsourced or social media data are a direction. Thank you.
Right, right. That's great. So I think this there's another point which Shailesh has also raised, which is more like if we're expecting a third wave in India, would that so the question goes like, with third wave being predicted to impact kids, is the correlation to increase with vaccination of variants escaping vaccinations? There are more correlations, but worthwhile seeing this in India or particular high risk rates. So are we going to see some sort of patterns with vaccination variants and age groups? I believe that's the nutshell of the question. Anyone in the back?
Yeah, so I can speak to that. So it does appear in a number of countries that we're seeing younger people being affected more severely. It's more on the age range of young adults or teenagers more than like little kids or infants. But we are seeing a shift down in age. So we saw this in the state of Michigan, and we're seeing it also. We saw it in Brazil. There's some evidence coming out of this happening in India as well. I don't know why. I don't think it's vaccine related for a couple of reasons. So you would imagine that if you vaccinated older people, maybe it would just appear that the virus is infecting younger people more as a percentage of the whole. But what we're seeing is this is actually true for absolute numbers. We're seeing in the States, we're seeing it in Brazil and India, not that many people have been vaccinated yet. So the vaccine isn't even really coming into play with this. So I don't know what it is about these mutations or variants of concern that seems to be worse in younger people, or if it's just higher death rate in general. So we're just seeing everyone sicker, and that is making people that weren't as sick, people in their 20s and 30s, appear to be more severe because it's just more severe overall. But these are questions that we are actively working on. Mung has data about death rates in the US with variants, and we're looking at age ranges. So this is one of the many projects we have going on right now. But I think it's really important.
Mm-hmm. Yeah. I can see Dr. Shah Jamil has his hands up. So please.
Yeah,
Dr.
if I could come in, there might be two possible reasons for younger people getting more affected in this wave. One could be that these variants being more infectious and younger people being more risk-taking and going out more, mixing more, could be coming into contact with the virus much more than older people. And also remember that the vaccination in India started with older age groups. So a larger percentage of older people have vaccine coverage compared to younger people. So possibly a mixture of both of these are playing a role. I don't think any mutations are going to be sort of age specific. Some mutations affecting younger people more than it possibly has to do with behavior as well as vaccine coverage.
Right.
So just a thought. I mean, there's no data really.
Yeah. Yes, definitely makes sense. And incidentally, one of the questions raised by Govind Jeevan was also on similar lines, that could it be that the older population largely decided not to venture out because due to the earlier warnings given to them due to their age group restrictions, and younger group people venturing out more. So basically rating it as a social phenomenon. And I believe, yes, it will be very interesting to look at this data. Do you think we can map mobility patterns and similar items to get an insight into this? Does anyone in the panel have anything about it?
Yeah, this is possible with Google Mobility. We have these data.
I see. That's awesome. That's awesome. Does Google Mobility also have segmented across age groups, or is it just mobility data?
That I'm not sure of. I'd have to look again. I don't think it's by age group. It's by activity. So it's like parks and public transport and retail and workplaces, but I don't think it's by age. Maybe they have that data and they're just for privacy reasons not sharing it. We could try to ask them.
Right. Definitely makes sense. So, and I think another question that Dr. Jamil had raised in the beginning of the talk was to you, Man, about how we're going to get the surveys to the rural population of India. So if you want to answer that out for the folks watching this.
Yeah, exactly. That was a conversation we had with the crowdsourcing team as well. And because of in rural areas, there might not be always the possibility of having online access to the website. For Karuna version 2, we are looking for offline access to the surveys, such as they would be able to save the draft. And when they get access to online, the draft would be sent to us so that we have the data, even if the person fills out the survey offline, it would still be kept until they get online access, and then that would be sent directly. And so multiple apps we are looking at, Kaisala for Microsoft or EpiCollect, etc., and those would be integrated with our Karuna version 2 application.
Awesome.
So
awesome.
Iman, one issue could also be language.
Yes.
English, I mean, there are only about 12% English-speaking people in India.
Exactly, yeah. So
that's
we have, that's a very important point. We have actually had a Hindi survey created, exactly, that we're currently, it's not being outputted as of now because we're still looking at some of the questions that need to be checked. So we're getting checks by people who know Hindi first language as well. And then when that will be over, there will be 2 surveys, an English survey, a Hindi survey. And we are also working on a volunteer effort for getting more languages. So more district languages to also be added to our survey. And if anyone here knows multiple languages and would like to participate as well, please join our Slack. We have a Spike translation channel, which holds a lot of volunteers, and we're always looking for individuals that know multiple languages to help us translate the surveys, because it is a very important aspect to getting more responses. Yes.
And one other thing, does the survey work only on smartphones, or does it also work on low-end smartphones? I mean, in India, while phone coverage is almost 100%, only 25% of the population has access to smartphones.
Exactly, yeah. So we are both doing a web interface on React and an Android interface that has the possibility. So there is an Android interface that you'll be able to download either on the App Store or in the Android store. And then you also have the possibility of adding a version of the app within your Android or your phone from the React app, so from the web interface, and then you can just click on it and be redirected to the website easily in case the app itself is too much of a bandwidth, too high in resources for your actual Android. So these are some of the steps we are taking, but we're always looking for more feedback. So if anyone here has ideas on how we can make this more accessible to people, we are always looking for more feedback as well. Yeah.
But just to add one more thing, I think just to follow up on Iman. So Professor Jamil, if I remember correctly, we are involving local bodies and chapters to help us connect to the rural areas. And I think Iman and the team are working on how to get these responses on a very simple spreadsheet format and then we elevate that to our to more fancier channels. So a spreadsheet, just so that the volunteers can simply collect the data, and then we store it offline, and then when the data is available, we take it on the web and we can analyze it. So these were some of the strategies. And also, I think there is a team with various language experts in Indian regional languages who are helping to translate the survey into various languages.
Exactly. Yeah, that's in the Spike translation channel. And if there's anyone else in here that knows more languages and would like to partake, it'd be really nice if they could join the channel as well.
Yes,
okay, thank you.
Definitely. So India being a country with more than 20 plus or even much more languages, I could be wrong with the number 20. So we'll look forward to having anyone who could help us in any of these languages. So please join our channel. And Dr. Jamil, to quickly answer one of the questions you asked, if you could port this to lower end smartphones, or let's say feature phones, as we're calling it in India. One suggestion which we could implement is something which we use for our vaccination app, is an SMS-based chatbot. Although this is not something we've integrated into the system right now, if there is a need exists, and if we have enough resources, we could think about putting up an SMS-based chatbot that could take the survey. So ideally linking it up with a toll-free service so that anyone with a feature phone can, because in the end, these surveys are mostly asking for a few numbers, like range values and selecting an option. So a lot of this could be integrated into a feature phone with these, unless there are very specific descriptive type questions, which becomes difficult for the person to type out, which I believe in the survey is very less. So yeah, that could be another possibility we could look at. That's great. So by looking at the charts, I don't see any new questions. But if there's any other question, please do message on the chat. And in the interest of time, I'll just stop the recording and stop the live stream at the moment. So thank you, everyone. Thanks, everyone, for joining us. We'll continue with an informal discussion. Anyone who wants to say can stay here, but I'm